get started. Again, good morning, everyone, and welcome to day 3 of our annual meeting. It's been fantastic. It's been we've had quite interesting plenary sessions, and also I've been going from one room to the next, listening to some of the discussions in the protocol team rooms, as well as also in the working groups and the committees and so on. And it's terrific to see the vibrancy of the conversations and the engagement by all of you. I think we're going to start now, without further ado, with our plenary session today that's entitled Prevention of HIV Special Considerations. And I'm very honored to present Ntando Yola, who's going to moderate this session. And many of you, of course, know Ntando. He is the HPTN Community Working Group co-chair, and he's also works at the Desmond Tutu Health Foundation in Cape Town, South Africa. He's been part of the HPTN for many, many years, and a strong advocate for HIV prevention around the world. So we're very lucky to have him as a leader of our community working group. And I'll hand it over to him now to present our speakers and moderate the conversation thereafter. Thank you.
Thank you very much, Wafa, and thank you. Yes, that's for Wafa. Well, and it's really great that we are here together on this last day of the HPTN annual meeting, and the very first plenary is bringing our attention to two important topics that are looking at HIV prevention and special consideration for people who inject drugs, and prevention amongst pregnant people. And so we have for this session about 45 minutes. That 45 minutes is shared equitable amongst the two presenters and as well as yourselves. And so I have tried to negotiate with the presenters to at least give 2 or 3 minutes so that we can have more time to discuss, but they told me that they're actually about 1 or 2 minutes over. So I don't know, we have to all work around that in making sure that we have enough time for engagements on these two important topics. So in terms of logistics and protocol, I think once we hear from both the speakers, we're going to give time for questions to all of us. And I think as we do that, I would like to request that we are mindful of those who are joining us online so that we are able to put in their questions, but also when you ask your question, be mindful of the person who is behind you so that we keep it going and have a great discussion on these two topics. So I'm not going to take any more time. I'm going to introduce our first speaker, who is Sunil Suhas Solomon, who is a professor of medicine and epidemiology at the Johns Hopkins University School of Medicine in Baltimore. And his research primarily focuses on preventing and treating HIV, viral hepatitis, and other infectious diseases among vulnerable populations, such as people who inject drugs. So I think that makes Sunil as a qualified person to address us on this topic. Over to you, Sunil. Please, let's give him a hand.
Good morning, everyone. Thank you, Ntando, for that lovely introduction, and the organizers for the opportunity to speak here today. So over the next 45 minutes, I will... over the next 15 minutes or so, 10 minutes or so, I will try and present to you what I think we should be doing in terms of HIV prevention among people who inject drugs. So these are my disclosures. So I want to just start with why are we here today talking about people who inject drugs? So I think as many of you in the room are aware, we are in the midst of one of the worst opioid crises the US has ever seen. Every year we break records in terms of overdose deaths, primarily driven by xylazine, initially by fentanyl and now by xylazine. The latest estimates we have at the end of 2018 was about 3.7 million people who inject drugs in the US. Right? And this was pre-pandemic, and we know during the pandemic, these numbers probably escalated even more. We also know that over the past few decades, HIV incidence had been declining among people who inject drugs, Unfortunately, we are also seeing outbreaks of new HIV infections in regions where we've never seen them before in the US. And if these current trends in overdose deaths keeps going, it is plausible that we will start seeing more outbreaks of HIV even in other regions where they are established, for example, like in Baltimore City or Los Angeles County. But this is not a problem only in the US. So globally, about 1 in 5 infections among outside of sub-Saharan Africa are driven by injection drug use. So there are very few estimates of incidence from longitudinal cohorts globally. But I do work in India, so I do have access to some of our data. So I just wanted to present 2 estimates from India. So this was a community-based sociometric cohort of people who inject drugs in India. We saw 159 seroconversions in 747 person-years of follow-up between 2017 and 2020. We had to stop follow-up because of the COVID pandemic, but that translates to an incidence of 22 per 100 person-years, which is probably unheard of anywhere in 2020. The second thing I want to show you is like trends in incidence among people who inject drugs in India. So there's 8 different cities in India. You will notice that everything dropped in 2020, primarily because access to HIV testing dropped. But prior to that, you can see we had multiple cities in India where people were actually seeking care. So this is not a community-based cohort. These are people with positive health-seeking behavior where you have HIV incidence over 10%. So it's very likely that in the community, the HIV incidence is going to be several-fold higher. If you look at it globally, we do have estimates of prevalence. So there was a last report that was put out in 2017. So it's about 15.6 million people who inject drugs globally, with HIV prevalence about 20%. And more recently, we're seeing a lot more reports of HIV even from Africa, from South Africa, Tanzania, Kenya. So it is becoming a global issue, and it's no longer a US or an Eastern Europe or a South Asia issue. But before I go into the solution, I want to talk about 2 of my all-time favorite HPTN studies, because a lot of what I'm going to talk about is related to these 2 studies. Not because Mike is in the room, but I think HPTN 052 really did revolutionize HIV prevention. Right? It set the basis for treatment as prevention, led to the U is equal to U, and we have these huge campaigns. We had Partner 2, Partner 1, Opposites Attract, all of which showed that you can prevent transmission by bringing people down to untransmissible levels. The second greatest thing is long-acting cabotegravir, both HPTN 083 and HPTN 084, right, which really has revolutionized HIV prevention. So yes, one is a treatment trial, one is a prevention trial, but they do have something in common. They both excluded people who injected drugs. There was an improvement. Mike excluded people who hadn't injected in the past 5 years, so it came down to 90 days, but they still excluded them. And so as a result, long-acting CAB is not indicated for people who inject drugs. We don't have any data on treatment as prevention or U is equal to U among people who inject drugs. Every study that followed was among serodiscordant couples who were either MSM or they were heterosexual. So does that mean it doesn't work? It probably does, but I don't have the evidence to show you that it does. And I think that is a big problem. So if we really are serious about ending the HIV epidemic and global AIDS control and all these things, I think it's high time we truly make sure that no one is left behind, including people who inject drugs. And if I can actually go a step further, I would almost say like we should be thinking about including people who inject drugs in every trial we do. We have like criteria where we say we want at least 30% to be people of color, 20% to be MSM. Why can't we say we also want at least 10% to be people who inject drugs? Because you're generating data at the same time. You do a stratified analysis, at least we know, does it work or does it not work? Because we're now stuck in a situation where we have these efficacious tools, but we don't know if it's going to work in people who inject drugs. So now moving on to what I think we really should do. Again, I wasn't kidding about those 2 HPTN studies because my first thing is antiretroviral therapy. We know it is the most efficacious tool we have to prevent HIV infection. HPTN 074 was a landmark study. It showed that we could improve access with peer navigation, counseling, and ART. We could improve access to testing, improve access to linkage, improve access to ART, improve viral suppression. But what is viral suppression? 40%. Right? So there's still so much to do in improving viral suppression in this population, which actually overflows into prevention. And then if you switch gears and look at what we did in India, we did contingency management plus outreach workers. And our viral suppression, this is both MSM and PVID, is about 50%. And that's where the 90-90-90 targets are. And if you're looking at people who inject drugs, it's only about 30%. Right, so before we jump into all these prevention strategies, I think we really need to focus on how do you get these treatment numbers up and how do we get more people virologically suppressed? Because if you can suppress them, you are preventing onward transmission. But it's not that easy among people who inject drugs who already have a lot of challenges adhering to oral medications, which is just further complicated by homelessness, unemployment, lack of access to good food, and stigma. So that brings me to the next question of what about long-acting antiretrovirals? Is this something that we could be looking at in people who inject drugs? But just like every other licensing trial, people who inject drugs were also excluded from the licensing trials for long-acting cabotegravir and long-acting rilpivirine. But that doesn't stop us because there is some data from WAD 86 that Monica Gandhi presented earlier. So this was among people who were unsuppressed, where they gave them, and who were not able to be suppressed on oral antiretroviral therapy. It's a small sample, it's only about 57 people, it's only 6 months of follow-up, but it is sort of a proof of concept that we can suppress them and bring it up to 97.5%, which to me is very acceptable and something which needs a lot more investigation of, is this a strategy we could be using among people who inject drugs? But then that brings up the question of acceptability, right? So this applies to both long-acting ARVs and long-acting PrEP. You are going to have these people who are going to say, no one's going to stick me besides for myself. But at the same time, I've also been working in India for many decades, and we did a trial of soft peg and riba for hepatitis C in India. People who got randomized to the non-interferon arm were very upset that they were not getting injections. And when people got that peg injection and they had those side effects, like, oh, that was awesome, that injection is working, right? So I think it's hard for us to assume that just because one population said this, it's not going to work in another population. So I think it does require a lot more investigation. But then that brings me to the question of resistance. So these are Sanger sequences of HIV-positive MSM and PVID in India with detectable HIV RNA. And as you can see here, these people have like extensive resistance to rilpivirine based on the Stanford database. So in this population, could you actually use CAB rilpivirine? Or is that something that we cannot be using in this population? And again, we have to think about what I think Jonathan Merman said yesterday is like not just about the trial, how do we scale it up? Yes, we can do baseline resistance testing and rule them out, but that is not going to be accessible in the real world. So in such populations, should we be looking at like a combination of maybe CAB and LEN? Is that something we could be looking at in this population? So that's a question to consider even before we get into antiretroviral therapy. And once we're on there, I think everyone recognizes that drug use is not an on-off switch, but it's a cyclical pattern. People inject, they stop, they relapse. When they've stopped, very easy to follow. When they relapse, much harder to follow. And given the long tail of antiretroviral therapy, what does that mean in terms of resistance to the drugs and also transmitted drug resistance? So that doesn't mean we shouldn't do these studies. It just means that we need to do trials with like a lot of long-term follow-up. So the next thing I will say is PrEP. So people, to me, represent an ideal population for PrEP, right? They're viral load, they have like low viral suppression, high incidence, inability to adhere to oral PrEP, so long-acting PrEP really works. Yet, the uptake of PrEP in this population is extremely low. It's only about 0.295 per 100 person years. And I actually went out and talked to a couple of people who inject drugs in Baltimore, and I said, what's going on? Why isn't anyone interested in PrEP? They said, well, we thought PrEP is only for gay men, right? And if you actually pay attention to it and look at all the commercials we have in the US, that's what it looks like, right? So if we want a population to start using a product, it's not just about supply, but it's also about demand and communication. So we should start communication while we're waiting for long-acting PrEP to try and improve uptake of oral PrEP. So there is preclinical data. This was a parenteral challenge in macaques compared to an intravaginal challenge, which was the basis of HPTN 084, look extremely identical. The results actually say that this requires a larger trial, yet no trial has been done to date. But we are definitely getting there. We have a phase 2 trial going within the HPTN, and maybe we'll start seeing more trials happen. But there are a couple of things we need to pay attention to, especially drug-drug interaction data about interaction with substances of misuse, interactions with medications, opioid use disorder. We can actually do efficacy phase 3 trials. We do have enough incidents. But then besides for the acceptability, it also brings up the question of delivery. Where should we deliver it? Through the MOUD centers? Can we use field-based delivery or mobile vans similar to what we're doing in 094? And could we target high transmission venues? So to give you an idea of what I mean by high transmission venues, so this is a socio-spatial cohort in India. So all these spots you see are actually GPS locations of injection venues. So this animation shows you the build out of the cohort over time. Each of those nodes represents one person. The lines show you the connections, and all the red lines show you incident infections. So you can see by the crowding, firstly, the networks are extremely complex. So doing one of those U is equal to U studies is going to be challenging. But I think what I really wanted to point out is like you will see that clustering of red lines in the middle. And so 71% of incident infections were tied to one venue. So what if we could take that van to that one venue, hit them with long-acting ART, long-acting PrEP, and wipe it out there completely, and that will have ripple effects across the rest of Delhi, right? So it tells you that there are also cool strategies we could be exploring at the same time. And once we're done with ART, substance use. Right, so I think harm reduction really is critical. And harm reduction by itself can reduce HIV incidence by as much as 50%. And so these are all the different components. In terms of pharmacotherapy, we have nothing for stimulants that are FDA approved. We have buprenorphine and methadone. But over the next 2 slides, I want to try and challenge you to newer concepts. For example, there is a long-acting buprenorphine. This was a randomized, double-blind, placebo-controlled trial, about 1,200 participants. And you can see that people on long-acting bup are able to stay drug-free, almost 50% of them, which is consistent with oral bup. But to date, there has been no head-to-head trial between long-acting bup and oral bup. So that's a trial that's lacking, but I think long-acting bup by itself, if it can reduce injection, could be a PrEP agent. It's not necessarily affecting HIV, but it could prevent HIV transmission. The second thing I want to talk about is treating stimulants with stimulants. We treat opioids with opioids, so why is this something we are shying away from? So there is some data from earlier on. The one on the top, they're both double-blind, placebo-controlled trials, and you can see that sustained release dextroamphetamines and methamphetamine salts really are extremely efficacious in reducing cocaine use, right? But this has really not moved forward, and we've been talking about mirtazapine and bupropion and other agents and naltrexone, but these effect sizes are much larger. But the one with the largest effect size is contingency management. It is not a pharmacotherapy, but if you were looking at efficacy, that is probably the most efficacious agent you have with the effect size of 40 to 60%. And so that's something that we should be thinking about in terms of stimulant use. So that was more about HIV, but I think the last thing I want to end with is health. Don't forget health, right? Because people who inject drugs are people. They need access to housing, employment, food, incarceration, and each of them is associated independently with HIV risk. So we really should be thinking of person-centric models. There really was a cool paper that came out in Nature recently, looked at cash transfers and how it impacted mortality in both women and children. Again, remember, there are women and children who are also people who inject drugs, right? So these are models that can be replicated. But I want to just end by saying that, yes, I presented 4 different components, but what we really should be working towards is how do we combine all these together? How do we provide status-neutral, whole-person approaches of HIV care for people who inject drugs? Right? And I think when you're designing an intervention, always remember they are people first, right? So just like you and me, food, housing, employment are priorities. And we need to figure out how we build those attributes into any intervention that we build. And again, to paraphrase what Jono said yesterday, I was like, we should be doing these studies, but we should also be doing them in a way that it does not stop with a publication, but it actually gets translated. So not just the PVID in the study sites, but it globally impacts the lives of PVIDs everywhere. Those are my acknowledgements, especially the participants of research studies who graciously take part in these studies that allow us to have all this data to make all these recommendations. Thank you for your attention.
And thank you for keeping the promise, Sunil. And very important message, people who inject drugs are people. And we turn it over to Sinead, Sinead Delaney Moretwe is the research director at the VETS RHI, VETS for Americans, not WEETS, in Johannesburg, South Africa, and a global health and infectious diseases professor at the University of the Witwatersrand in Johannesburg. And her research interests span in the intersection between sexual and reproductive health and infectious diseases, particularly in adolescent girls and young women. She is the protocol chair of HPTN 084 and a member of the HPTN Executive Committee. And I think she's actually the queen of HPTN 084, effectively CAB LA. Welcome, Sinead.
Thanks very much, Ntando, and you've identified yet another unpronounceable name that I'm associated with. So I just wanted to thank the HPTN leadership for inviting me to give this talk that I think is going to have increasing relevance to the network over the coming years. And in this talk, I hope, if nothing else, you take away these key 3 messages: that individuals of reproductive potential have, who are mainly but not exclusively cis women, have overlapping risks for HIV and pregnancy and need information about the safety of HIV prevention products when used in pregnancy. And that currently there's a paradigm shift underway and a call to action to researchers like us and networks like ours to reconceptualize our approach to the inclusion of pregnant and breastfeeding women in trials under an appropriate set of conditions. And really that the HPTN has an opportunity in trials of new biomedical products and integrated strategies to generate evidence around the gaps that exist about the safety of these interventions in pregnancy. That to do this will require multiple stakeholder engagement, and hopefully I can share some lessons from HPTN 084 in that regard. So in some regions of the world, as many as 60 to 80% of people living with HIV are people of reproductive potential. And in the same regions, fertility rates are high. In sub-Saharan Africa, the fertility rate is 4.6 births per woman and higher than any other region in the world. In addition, in sub-Saharan Africa, we have the highest rates of unintended pregnancy that range from about 49 to 145 per 1,000 women in Uganda. And these people are all going to be in need of HIV prevention products that can be used safely during pregnancy. The other point to make is that pregnancy itself is a time of vulnerability to HIV, and this was an elegant study done with the Partners in Prevention and Partners PrEP data that really quantified the probability of HIV acquisition in women per sex act and really showed that in later pregnancy and in the postpartum period, compared to non-pregnant people, there is a higher risk for HIV acquisition. So individuals who wish to safely conceive will also need HIV prevention products that can be used safely during pregnancy. But despite this obvious need, what we've actually done is to often have individuals of reproductive potential excluded from trials of new agents, particularly including antiretrovirals. They're often required to use contraception if they join the study. They have to discontinue study product if they become pregnant. And this approach has really been born out of concerns about the direct and indirect effects of medications on the developing fetus, particularly during the period of organogenesis. But it's also important, and that's most illustrated, I think all of us know the images associated with the thalidomide scandal in the 50s and 60s, but also that there are actually concerns about the indirect effects of some of these medications that may increase the risks for things like preterm birth or have impacts on glucose homeostasis that also have fairly severe consequences for the fetus. But what we're increasingly understanding is that by adopting this approach of excluding people from pre-licensure trials, what we've really done is shift the harms from small numbers of participants who are well monitored in clinical trials to much larger numbers of individuals in routine care settings where medications are often used off-label with limited information about the safety of them in pregnancy. And so even in the field of HIV, it may take up to a decade after a drug is approved, actually before we have data on the safety and pharmacology of that drug in pregnancy. And the consequence of this is that we have many more pregnant women exposed to drugs with uncertain data around safety, efficacy, and dose. So because of this, multiple stakeholders in recent years have really voiced concerns about the exclusion of pregnant women from pre- and post-registration trials because of the harms really for the greater community where these products are eventually used. And a NIAID-funded group, the PHASES study, actually has articulated a helpful set of conceptual shifts that help us to facilitate the inclusion of pregnant and lactating women in trials. And this is to rethink of pregnant people not as a vulnerable population, but rather as a complex population that have additional needs. And rather than protecting them from research, we should protect them through research. And rather than automatically excluding them from trials, we should really be thinking about ways to include them in trials, with the goal that ultimately through the practice of well-conducted research, we can generate data on safety of drugs in pregnancy prior to registration. Button's not working. Okay, there we go. So, this has really led this in December of 2020, WHO and Impact hosted a series of virtual workshops to better conceptualize how we can actually take this aspiration and make it practical. And they are through a set of consensus workshops involving multiple stakeholders, really articulated a set of principles for how we should study new antiretrovirals, both for treatment, but in the case of the PTN, for prevention in pregnancy. And essentially, these principles argue that if a drug is effective in non-pregnant adults, and we can demonstrate adequate drug exposures in pregnancy, then we don't really need to do efficacy trials in pregnant women. And if the drug is efficacious in non-pregnant adults and we can demonstrate adequate drug exposures, then we also don't need to demonstrate efficacy for prevention of vertical transmission, because we can make assumptions that the products work the same way. But to do this, we really need all new agents to be studied in pregnant women, particularly around the pharmacology, to discuss optimal, rather document optimal dosing and ensure that we do have these adequate drug exposures. And ideally, particularly for priority drugs, we should have dedicated studies that are going to assess clearly articulated safety endpoints for both pregnancy, but also for maternal and infant outcomes, and that these should be conducted in trials for antiretrovirals that are expected to have broad use. But trials are not expected to generate information about rare outcomes like teratogenicity. That's going to need to be done in surveillance or post-marketing surveillance. And really, it's going to be important that once we know about dosing and short-term safety, that these drugs be made available for use by pregnant and lactating women. So someone asked me yesterday, yeah, but kind of what does that mean? How do we kind of avoid the risks that may be associated with these medications? And that's a really important question. And through these consultations, what has arisen is essentially the recognition that we need to be much more active in advocating for having early preclinical data that is either, the fetal, early embryonic and early embryo-fetal development studies, as well as the pre- and postnatal development studies, and that we have this data as early as phase 2 or phase 3, so that with that data, we can then allow women in trials to continue dosing during pregnancy, generate more data on the pharmacology and safety of these new drugs while women are in these trials, and if needs be, conduct additional safety studies that are adequately powered to report on short-term safety outcomes, but also build capacity for comprehensive surveillance. And I would say that since these conversations, what we're seeing is a number of trials for HIV prevention products that are now allowing the people who now have relaxed requirements around contraception and are allowing individuals who become pregnant in the trial to continue dosing during pregnancy. So I also want to point out that we need to get consensus around what are important safety outcomes in the situation of pregnant and lactating people. And we all become quite fixated about congenital anomalies, but they're not the only safety endpoint, and in fact may just be the tip of the iceberg. And there may be far more frequent outcomes that cause far more severe consequences for infants that also need to be assessed, including preterm delivery, low birth weight, small for gestational age, and fetal loss. But also we should recognize that there are important consequences for maternal health that may have impact for infants, and there may be developmental outcomes for these infants that we may want to also report on. It's also important to recognize that these events can occur in the absence of any medication in our setting, and the frequency of these events may vary by geography. And knowing the background rates helps us to understand sort of what we could expect absent of an intervention, and what we need to do, I think, to power our sample sizes to exclude more or less frequent events, recognizing that rare events like congenital anomalies may need multiple studies. But this argues for generating a set of harmonized endpoints for studies, and also illustrates the importance of having a robust comparator group so that we can make comparisons of safety outcomes in the intervention group and compare it to what is known with more established drugs. So now I want to tell you a little bit about what I think we are learning from HPTN 084. You all know that these studies, or 083 and 084, transition to the open label extensions. And what we have done is build a sub-study for anyone who was exposed to cabotegravir either currently or and chooses cabotegravir or was randomized to cabotegravir previously. And if they're pregnant, they are eligible to join the pregnancy study, choose active dosing of CAB, but are not required to. And we follow those women and their infants through to 1 year postpartum, and are trying to address important questions around safety and the need for dose adjustment during pregnancy, as well as generate data on CAB during lactation. So since the start of the OLE, we have seen 268 pregnancies. Now that people know that cabotegravir is effective, they are all becoming pregnant. And that of those who are eligible for the sub-study, we've seen about an 80% acceptance rate for participation in the sub-study. And to date, we have about 44 participants who've had at least one postpartum visit, so these are the babies of 084. But cumulatively, since the start of 084, we've actually had 465 pregnancies. And 394 of those have been CAB exposed, with 232 live births, 191 of those which are CAB exposed, which is a really rich and important data set that will inform many future initiatives and recommendations for women about what we know about the safety of cabotegravir in pregnancy and lactation. One of the things that we were very conscious of going into 084 was the fact of the dolutegravir safety signal that was in fact identified at this meeting 5 years ago, and meant that we had to take steps really to restrict pregnancy in 084. And because of that, prior to implementing this new protocol, we had a community consultation in 2021. And I think the point I want to emphasize is these changes require multiple stakeholders to move us forward. And what this consultation highlighted for us is that there still are many concerns about the safety of antiretrovirals in pregnancy and the need for information. I think this is a call to the HPTN Community Working Group to really continue to work with us to address some of these community education needs. But the other key message is that pregnant women are part of a social network. There are many people who are invested in the outcomes of pregnancy and have opinions, and it's important for us to recognize that. And so it's important to develop a range of materials that allow pregnant people to weigh up their risks and benefits in such a way that they can make decisions that are informed for them. So in conclusion, really, I hope that I have demonstrated that this is an issue that we should engage with because there are overlapping risks for HIV and pregnancy, that there is a paradigm shift underway and a call to action to our network, really to think about ways to include pregnant and breastfeeding women in our trials going forward. And it's also an incredible opportunity, I think, for the HPTN to contribute evidence to contribute robust data to the evidence gaps that exist, but also to educate communities and to support participants to make decisions about participation in these trials so that we can build the evidence base both for current and future products. Thanks very much. I lost my last slide. With the acknowledgements.
Well, thank you very much. Thank you. And there is your acknowledgement slide. And I can finish it for you. We acknowledge all those who supported this research. So, well, I think the message is really very clear, and to close the data gaps by including people who inject drugs and pregnant people for HIV prevention. And it's question time. We have Uncle Stan right there, and please go to the microphone. We'll go in this order and come back, and we'll be monitoring people online. Over to you, Uncle Stan.
Thank you. I'm Uncle Sten from Yale. I want to challenge and see if, Sunil, you agree with me. I don't think in a study of whether a product prevents heterosexual transmission that including 10% of the population as injection drug users will clarify the question. For example, I think it was absolutely correct to exclude persons who inject drugs from 052 because it would not have enhanced the answering of the question at hand. It would have actually created chaos in the database. We would have had to exclude those people in the primary analysis anyway. However, if you're challenging us to say, look, as 052 is progressing, we should be immediately designing the follow-up study in injection drug users, there I would agree with you. And perhaps the gap between 052 and 094 was too great. There I would say the self-criticism for the network would make a lot of sense. But I heard you criticizing 052, 083, 084, not including injection drug users. I wouldn't agree with that.
So I think there are two different questions, right? I completely agree with you that ideally we would need a study among people who inject drugs, right? Like you said, if 083 and 084 worked, if 085 was the PIVOT study, perfect. But that never happened, right? And so that's the problem. And I think right now, if I understand correctly, based on what the FDA recommendations are, is you just have to show target concentrations in the population. You don't actually have to show efficacy. That target concentration can show efficacy in another phase 3 trial. Right? So something needs to be done. And I think the reason I'm saying include them is because we need some data. Right? Yes, I completely agree with you. It will be chaos. But we are not going to get rid of HIV by answering the easy questions. Right? It's the hard questions, and how do we actually solve that? And I'm not really criticizing 052 or 083, 084. I'm just pointing out that there is a lack of recognition that this population accounts for 10% of burden, and we exclude them. Right? So I think that's something we need to think about is, yes, I 100% agree with you. If we plan any study, even one of the BNAB studies, right? For example, like we're looking for populations with high HIV incidence. Why are we only looking at heterosexual populations in sub-Saharan Africa? Like, have you thought about doing a study of BNABs in people who inject drugs, high HIV incidence, right? But that never happens. So that's why I'm saying, like, if we can't make that happen, at least include them so we have some data to show whether it works or not. Exclude them. If you need a sample size of 1,000, recruit 1,100. Let the 100 be people who are excluded, but you have that data. Like right now, we have nothing.
Sunil, wait, one thing, I need to give a historical point here that's really important for you and Sten. After 052, there was actually two big things, commitments happened. One was to understand transmission probabilities. The reason PWIDs were excluded because we were trying to understand sexual transmission. We immediately went to NIDA and wanted to do, and went to Nora Volkow and wanted to do 052 in PWID. That became 074, but underpowered to address the question. So we very much appreciate you citing 074, our Vietnam study, and we had hoped to address exactly what you wanted, prove definitively treatment as prevention of PWID. What we did show in that study is the benefits you put on a slide, as well as mortality reduction. You may remember that if a PWID who was untreated went for treatment relative to people we couldn't enroll in treatment, there was a 50% roughly, or very high reduction in mortality. Irving Hoffman is here. He's one of the people who led the study. So there was a commitment to what you wanted to accomplish, lack of funds.
All right. Thank you. There was commitment. Deb?
Hi, I'm Deborah Donnell from the Stat Centre. This is a question for you, Sinead, and I wanted to get your perspective on whether or not the approach to studying drugs in pregnancies should be, should be approached the same way with topical products. And what I'm reflecting on is in the MTN, they came up with this very logical, consistent approach to studying during pregnancy with topical drugs, which is different than what you were proposing. And I understand the difference in the context, but is there a context-specific thing for studying drugs during pregnancy given topical versus systemic nature?
Thanks, Deborah. I think that's a great question. I think the key difference between systemic and topical products is probably how much drug exposure we think the fetus gets kind of in utero at the time of delivery, but also during lactation. And that sort of may influence how we think about sort of what we need. But from the consensus discussions, I think there is a desire that we have as much preclinical data as possible as early on in the development of these products. Having said that, I know the work that, or my impression of the work that was done around the ring was really sort of to be as cautious as possible, given that we hadn't really had some of these sort of consensus discussions yet. And so in order to be as cautious as possible, there was a focus on demonstrating safety in late trimesters and then working into early trimesters. The difference for products like long-acting agents like cabotegravir or lenacapavir is that you already have drug exposures at the time of conception. Removing that drug, and as we've shown in 084, you have exposure all the way through pregnancy and through to delivery. Stopping that drug is not really going to remove the exposure. And so, kind of this argues then for the opportunity really to continue dosing during pregnancy if women consent, in order to collect that really important pharmacology data, which will tell us whether we need to do dose adjustments because of the physiologic changes that occur during pregnancy.
All right. Yes, sir.
Yeah, thank you very much, and thank you both. Really fantastic presentations. I guess, Sunil, you're really asking us to have a shift in paradigm and push the envelope and try to think whenever we're designing a study, is there a reason to exclude persons who inject drugs? I think you're right, is that somehow in people's minds who are in the research arena, we thought of this is kind of a separate population we get to when we get to. But it's not central often at the beginning of actually trying to answer the question. And I do think that it behooves us all, as we design studies, and everybody in this room is involved in this, is to ask that question: is there a reason to exclude the people who inject drugs? It's become kind of too easy to just say we exclude them because they're separate and different, but you made a compelling argument. I do think we are also doing the same thing for pregnant women. I think we're trying to have the same approach for adolescents. Is there a reason to exclude them from a specific study? So I do think it's very helpful to think that way, and thank you for highlighting this issue. Thank you.
Thank you. Thank you very much. We have a question online, and it's coming from Manju, who is highlighting, Sinead, that, in fact, thank you for a clear and compelling presentation, sharing, and she's also sharing an AVEC or phases action that specifically calls for multi-stakeholder advocacy for more inclusion of PLP in research and an advocate's guide. But can you talk more about the inclusion of pregnant trans men and people who identify as gender non-binary?
Yeah, thanks. A great question, and I think something we're starting to get to grips with, both sort of in the development of prevention products for gender diverse populations assigned female at birth. I think from the little data that we have, and we have some data from the US, but actually I would say probably no data from other regions of the world where the risks of HIV are high and the risks of pregnancy are high, is that even individuals who don't identify as cisgender women have reproductive potential, and even in the context of gender-affirming hormone therapy may still become pregnant. And kind of pregnancy may be a kind of incredibly uncomfortable experience for those people. So it's important that we, and that was my opening comment, that the majority of pregnant people will be cis women, but we shouldn't say exclusively, and kind of we should include all people of reproductive potential who are going to have sort of important additional questions perhaps about the use of other drugs, but not so much during pregnancy, but perhaps in the postpartum period. And we need to understand sort of the size and scale of these populations and how to kind of best involve them in this research as well.
All right, thank you. And I'll give you just 10 seconds to give us your closing remarks. And I mean, perhaps on the call to action that you gave us today, what are some of the practicalities that you really think in taking all of this work of inclusion forward should be? Both of you.
For me, I think it's probably going to be similar to what Sinead also presented, is like, I think exactly what Wafa said is, think about it when we're designing trials, because it is the easy thing to do to say, okay, we're going to exclude people who inject drugs, but does that actually make sense? Because I 100% agree with what Mike said. 052 was landmark, and it's probably the best study ever. There should have been a logical follow-up to it. Unfortunately, we know what the funding situation is. Right? So if you do that one trial and you show something, it's going to be very hard to get funders to come back and fund a study to show the same thing in a different population. So think about that as well when you design a study, because if not, like every follow-up study excluded PIVOT because 052 didn't include PIVOT. It's not 052's fault, but it's the way the funding world works. So just think about it when you're designing a study. Does it make sense to exclude people who inject drugs?
Thank you. Sinead.
Thanks. I think this is an exciting opportunity for the HPTN. We are at the sharp end of the development of products for HIV prevention. I think we should embrace these ideas, but we should recognize that it needs a multi-stakeholder engagement. Not everyone is where we are at the moment. We're going to have to work with regulators and ethics committees and communities to really encourage them to see the value of this approach. And I really agree with Wafa's points that we need to be asking ourselves not why, but why not.
Well, thank you very much. And that right on time, and that takes us to the next session on rumors, myths, and untruths. Otherwise, thank you to our panelists, and thanks to you all.
Hi, everyone. Let's get started with the next session, which is entitled Rumors, Myth, and Untruth, the Use and Misuse of Media. I want, before we get started with our panel and my introduction of the panelists, I would like to do a little exercise. So can everyone stand up? Stand up, everyone. Up, 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 up. I want everybody standing up. Okay. You can stretch a second if you want to. And then now, those who have never heard a rumor, spread a rumor, or witness a rumor being spread can sit down. All the rest stays up. Oh, there's one person there that I see has never, is he a liar or is he telling the truth? Thank you. So I can safely say that rumors are 100% prevalent in our society, or at least in our community. So it's an important topic. And we are very lucky today to have a wonderful panel of people who will be talking about rumor, and then an expert who will explain to us a little bit how misunderstanding and misconception are being spread, or why are they believed in. So it's my pleasure to introduce first Emily Vraga, who is an associate professor at the Hubbard School of Journalism and Mass Communication at the University of Minnesota. And Emily's title is, for her presentation is What Can I Do Confronting Health Misinformation in the Digital Media? Emily, please.
Thank you for having me here today. This will necessarily be very brief because I want to have a lot of time to converse with my fellow panelists about what we can actually do. So I'm going to give very top-line information on three main elements of misinformation. First, the way in which social and cognitive factors shape processing and lead us to believe misinformation. Two, the way journalistic norms produce misinformation and reinforce it. And then three, the unique role that social media plays in reinforcing and invigorating its spread. So first, why do people believe misinformation? To vastly oversimplify, there are two main things that often occur. First, there are times we want to be accurate. We really do want to process information and have accurate beliefs, but there are cognitive biases that get in the way. Those could be things like, I'm not thinking very carefully at the moment. It could be not paying attention to relevant source cues. It could be the fact that things that are familiar are seen as more likely to be true, right? So in those cases, we can think about bolstering people's ability to follow those accuracy goals and inhibiting some of the cognitive biases that prevent us from getting there. Sometimes we're not trying to be accurate, though. Sometimes instead we're driven by generally directional goals. Our social identity. We want to be right, but more importantly, we want to be liked. We want to fit in with our in-group. We want to align with our values. We don't like information that flies in the face of what we already believe, because we could experience cognitive dissonance, and that's really uncomfortable. We don't want to be at odds with people who we like, people who support our worldview. And in those cases, accuracy might not be more important, and therefore we need to think about how we can affirm those when addressing misinformation. For both of these, trust is fundamental. Trust matters for both accuracy goals. Things that I trust are more likely to persuade me, as well as directional goals. The people I trust depend on who I am. And when we think about the definition of misinformation offered by the US Surgeon General, it talks about it being defined by the best available evidence. But who gets to produce that evidence? And are they seen as trustworthy by the communities that you're trying to reach? To just give you a snapshot, because this is something we've all experienced, looking at trust in the CDC in the United States, you can see the cliff that it went off among Republicans in the beginning of the pandemic. From being an organization that was trusted fairly widely across party lines to being one that was trusted by Democrats and not Republicans. It's not just a single organization. The Pew Research Center has demonstrated a very similar trend when we look at trust in medical scientists, for example, where Republican distrust is growing throughout the pandemic. And this, of course, has real consequences. We've seen these gaps in terms of deaths related to COVID, especially after vaccines were available, where people living in Republican areas were much less likely to get vaccinated and much more likely to die from COVID. How do journalists and media actually propagate misinformation? Take this headline from last year: healthcare workers would rather get fired than get vaccinated. This is concerning, of course. These are our medical professionals, and it certainly makes it sound like this is a huge problem. And anyone refusing to get vaccinated, especially in the medical space, is. But when you read on, it's 15% of workers who are saying this, and in some cases it's only 5% who are actually refusing to get vaccinated. So the headline is not reflecting the reality well. Moreover, when they updated it a month later, thousands got vaccinated. But the number of people who are likely to see this update is much, much smaller, the ones who saw the original study or the original headline and thought, wow, there's a lot of disagreement among even our medical professionals about vaccines. This is chalked up sometimes to what we call false balance. So looking in the beginning days, the early 2000s, news coverage of whether or not the MMR vaccine would cause autism, you can see there are more studies that are claiming yes, without offering the counter, no, than there are just the correction. And there are a lot of studies that are offering both without necessarily giving the weight of evidence that most of the scientific community knows that this link is not present. This isn't an old problem. Michelle Bachram from Minnesota was a presidential candidate about 10 years ago. She made a claim that the HPV vaccine would cause mental retardation. 50% of news articles reported on that claim without offering any kind of context, without offering the balance or the correction. So false balance is a problem in and of itself when you have both sides presented equally. It's even more problematic when you're presenting only one side and not even giving that correction. In the early part of COVID-19, 72% of Americans said they had seen conflicting health information. And that makes sense. There was a lot of conflicting health information. COVID-19 was a new disease. There was a lot we didn't know, and there were a lot of conflicting guidelines. This matters because conflict among health professionals, among politicians, doesn't just affect our perceptions of that particular activity, but our willingness to follow guidelines on that issue, and can spill over and affect our perceptions of other issues. So if scientists can't agree, for example, on nutrition, why should I trust them on vaccines or anything else? Finally, misinformation reinforces these trends. One study, and this was before the pandemic, a meta-analysis found that 33% of vaccine content on social media is misinformation. It does vary depending on what kind of vaccine you're talking about, which platform you're looking at. But this is also not just vaccines. There have been other studies that look, for example, at cancer misinformation and came up with 32% was misinformation. So this is a real problem. And it's also a gap. I tried really hard to find studies on HIV misinformation, AIDS misinformation, and there weren't any. So I would assume that the levels are similar, but there actually isn't data on that point. Misinformation tends to be more viral. One really large study of Twitter looked at information across a wide domain and found that the truth took 6 times longer to reach 1,500 people and was more likely to be retweeted. This is linked to the fact it can be very emotional and it can be novel. When you're making something up, it's easy to be unlike anything anyone's seen before. And we are naturally inclined to read that, to retweet that, to share that. Features of the online environment reinforce this. So earlier this year, I was trying to find out whether my 2-year-old was eligible for a booster. He wasn't, so I entered it into Google and found 48 million results. Now the problem is when I'm faced with that much information, I'm not going to carefully read it. I'm going to go to easy answers. So it actually makes information easier to spread. There's both a lot of information and it's hard to find. Here was the first page of my search results, a bunch of the vaccine creators rather than authoritative sources. It took me a while before I finally found, okay, here's a governmental source, which took me to the Find COVID vaccines, which finally got me to the CDC, where I found out that in February he was not eligible. That's a lot of work and a lot of work people aren't willing to do. This is also a strength of social media. When I tried again 2 months later, the first search result was the CDC. When I tried a month later using incognito mode, the first result was the pediatric vaccination at Minnesota. So we are seeing changes. These changes aren't always good though. So this is David Montgomery. He's a health journalist in Minnesota. He did great work during COVID. I followed him religiously to know about our wastewater data, for example. You can see that he's credible from this blue check mark, right? When I tried searching in February for COVID-19, the first thing that came up was Chief Nerd. He's claiming, of course, that COVID vaccines caused death. He had a lot more retweets, and he had that brilliant blue check mark to tell me that it's credible. So things that used to work might not work anymore. So as we figure out, here's how I can navigate social media, it changes on us. And so we're always faced with new challenges to define what is true and false. So what can we do? That's what this panel is going to talk about. 3 things I think we can consider is how we can promote high quality information, especially weight of evidence, especially scientific consensus. How can we pre-bunk common misinformation techniques and claims so that people have resilience before they see it? And finally, once it still continues to spread, how can we debunk that misinformation by saying what's true and leverage community networks to do so effectively and efficiently? Thank you.
Thank you very much, Emily. That was very insightful, and hopefully will generate a lot of questions. Remember, you will be able to ask a lot of questions at the end of the panel, and you can also post your questions on the chat. So now I'd like to turn to our panelists, and I had a slide, but maybe it's not coming up. It's okay, I'll introduce the other panelists. It's totally fine. So among our panelists, our first panelist is Laila Montero. Laila is an experienced community educator at the Institute de Pesquisa Clínica Evandro Chagas. I hope I didn't butcher that too much. It's the CRS in Rio de Janeiro. She is responsible for engaging population deemed at risk for acquiring HIV, including transgender people. Laila also promotes HIV prevention among the transgender community and develops strategy to expand transgender participation in the HIV prevention clinical trials. Next to Laila is a translator because she doesn't speak English, so just be mindful when you ask her question to be also making sure that the translator can translate into Portuguese. Next is Sissi Suna, and she is an HPTN Community Working Group member and HPTN 084 protocol representative. She has worked in HIV prevention over 20 years, and she's at the Baylor, Uganda research site as a community engagement liaison, and she's been there for 7 years. She's been involved in HIV clinic and vaccine studies for different networks, including the HPTN, CoVPN, and IMPACT. She oversees the implementation of community engagement strategies and work plans for new and ongoing study. And then finally, Rondalaya De Shields is a member of HPTN 064 and 102 study team, and she's the director of the Infectious Disease Practice Prevention and Clinical Research Studies at Rutgers New Jersey Medical School Department of Medicine. She has more than 21 years of experience in HIV care, treatment, and prevention. Her passion is to improve the lives of underserved population with a focus on women and LGBTQ communities. She does enjoy nursing and developing programs to help promote community and population health. So let's give a big clap for our panelists. And I'd like each of them in turn to talk a little bit about how they have encountered misinformation and rumors in their work and how that has challenged their ability to support the different HPTN studies and protocol they've been involved with. So why don't we start with Laila?
Bom dia a todos. Boa noite a quem estiver online em determinada parte do mundo. Primeiramente, eu gostaria de agradecer essa oportunidade de estar participando desse meeting, dessa reunião e dessa mesa, que é de extrema importância para nós que somos do Brasil, né? Eu me chamo Laila, trabalho lá na Fiocruz, na Fundação Oswaldo Cruz. E, primeiramente, quero destacar o que foi dito pela nossa colega na apresentação dela, como a participação da mídia, que foi uma coisa muito importante na divulgação, né, no combate às fake news. No Brasil, nós ainda temos algumas grandes emissoras de canais de televisão que são conservadoras e partilharam muito dessas fake news que atingiu diretamente as comunidades mais pobres do Brasil.
Good morning or good evening for those who might be online. Before I start with anything else, I'd like to thank you very much for this opportunity to be part of this HPTN meeting. It's very important for us from Brazil to be here. My name is Laila. I work for the Oswaldo Cruz Foundation in Rio de Janeiro, and I would like to talk about the role of the media in promoting fake news, especially in Brazil. We have a number of broadcasting channels that are extremely conservative and have been responsible for the promotion of fake news.
Sendo assim, nossos últimos 4 anos com o nosso principal governador, que é o presidente foi o presidente Jair Bolsonaro, ele foi o principal que difundiu as fake news, a principal pessoa que difundiu fake news. Foi contra a vacina, contra a pesquisa clínica, contra os cientistas, contra a OMS, que é a Organização Mundial de Saúde, né, e estava difundindo que ivermectina, né, e algumas outras substâncias que não precisava de vacina, que aquilo curava e protegia contra a Covid. Nós carregamos um peso de milhões de pessoas que foram mortas brutalmente pelo vírus da Covid, e mesmo assim essa fake news atingiu em cheio a nossa comunidade, principalmente comunidade LGBT e trans.
As you might be aware, we went through 4 years of conservative government with former President Bolsonaro, and he was largely responsible for all the fake news that we had to endure in Brazil. He was against everything that was science-based. He was against the WHO, he was against scientific research, and he was promoting medications that were useless in the fight against COVID, and he kept claiming that vaccination was not needed. As a result of that, there were millions of unnecessary deaths. And the fake news, they had a especially negative effect in our community, the LGBTQ and the trans community.
E devido a esse cenário, atualmente nós estamos enfrentando um grande desafio, que é a reconstrução de todo o nosso sistema único de saúde, principalmente na questão da vacina, né? Porque a vacina no Brasil ela foi desacreditada. Antes, uma vacina de sarampo, por exemplo, tinha uma cobertura nacional e todos se vacinavam, a cobertura era maravilhosa. E hoje em dia nós estamos para conseguir vacinar, por exemplo, contra a gripe em níveis críticos, que nós temos que prolongar as nossas campanhas de vacina.
Just to give you a better idea of the current scenery and the status of healthcare in Brazil, we are now facing a major challenge. We have to rebuild our single health system, and we have to rebuild a vaccination coverage that nowadays is not good. For instance, in the case of measles, we had excellent coverage, which is not the case anymore. And also with the flu, we have to start new vaccination campaigns so that we can find ourselves at the levels we used to have before.
Para finalizar, a medida que nós adotamos no nosso centro de pesquisa, que é a Fiocruz, Foi importantíssimo ter uma educação comunitária dentro das comunidades, junto com a comunidade, com ONGs, com serviços de assistência social, ou seja, núcleos de outros serviços que fizemos parceria em levar as informações corretas e passar também fontes corretas para essas pessoas consultar e espalhar dentro das suas respectivas comunidades.
I'm going to try to wrap up by telling you that it was essential for us to work within our research center, Fiocruz. And what we tried to do, we used a campaign for community education. We worked with nonprofit organizations, with social assistance and social care, so that they could enable us to take good, reliable information into the communities we were trying to cover.
Thank you.
Thank you very much. Now let's hear from Sissi. Please go ahead.
Good morning to you all, and thank you for inviting me to share experiences from Beira, Uganda, as well as from Uganda, the country. Can you hear me? Hello? Can you hear me now? Sorry, thank you so much for inviting me today to share with you our experience regarding media misinformation. Yesterday, Nelson presented that communities are not controlled settings, and there are unpredicted challenges which can happen at multiple levels. So the same applies to the misinformation which can be passed on to different communities within our setups. The experience in Uganda dealing with communities and misinformation, or the myth and the untruth, saturates from the communities we live in. And the media has been very instrumental in handling such information. What we have seen is that I would give an example on HIV infection in Uganda, as most of you might recall that HIV originated basically more from Uganda, and during that time we had information circulating. There was a lady called Nanyonga, and if you could take the soil which was giving out, you would be cured from HIV. And that saturated without limitations, that is, so many people flocked to that area to go and pick soil in order to get better. However, we have seen over time that the media, much as there are people who are passing on different information, which sometimes is untruth, they misinform the public. There are also times where we have seen that media has gone ahead to support us, to tell the communities the truth in those misinformation which has been passed on. I would also give an example on COVID. When we are starting a COVID study, and also even before that, when government was encouraging people to go for vaccination, people feared and they thought that this was an avenue to wipe them out. And even before people could go in for vaccination, people already were fearing, and this was circulating among the communities. There are untruths which circulate so quickly like a wildfire within communities. However, we need as a community to go in. How do we approach people within our different communities and give them the facts that this is happening and this is not happening? and how do you relate on that message? We need to use different and multi-sector stakeholders and provide the information, and also put in place avenues on how do we detect that there are media misinformation moving on into the public. We have also gone ahead to use and work with the Ministry of Health, especially if the misinformation is on health issues. Also, we have political figures in the government, like Kabaka of Buganda. He's a UNICEF ambassador. He goes into promoting male involvement in HIV testing, and the people listen to him. So when we use and work with such figures in the government, people listen and they can go ahead and do the needful as they are being asked. Then we also have champions. At Baylor, Uganda, we have champions where we have young people who are living with HIV go out to inform the public about the importance of testing for HIV and also adhering to treatment. So those are avenues which can help us to curb on the misinformation in our communities. Then we look at the media houses, because this information passes through the media houses as well as through people. Print media, you go to the radio stations, you work with the TV. So we involve ourselves with such different media outlets to pass on the information, to go out, and also the communities, especially the community advisory boards. They are our voices. So we ensure that we pass on information to them, we give them the facts, and we also identify where the gaps are within the communities. Because if we don't have grassroots community organizations to support us, then you find that it might be very, very difficult to pass on the correct information among the different communities we serve. Thank you.
Thank you so much. And now we can hear from Arundhaya. Please go ahead.
Hi, everyone. It's always a pleasure to participate in the HPTN annual meeting, so thank you. So one big thing that has impacted our work and definitely impacted by the misinformation in print and in the social media arena is PrEP. Many misconceptions and myths and rumors persist around the topic of PrEP and HIV testing. PrEP, one of the biggest things that we hear often is that PrEP is not for me, PrEP is not for women. And most of that exists from the lack of us being represented in the marketing of PrEP. Oftentimes, when we encounter many women, they often say, you know, when they see ads on their social media, Instagram, Facebook, Twitter, that they're often the promotions for men who have sex with men population, and they feel as though that they're not at risk. So that's something that we really have had to work on, and it's a continual issue that arises in the population that we serve. So a couple of things that we've done over the years. We've done a lot of assessments of providers, provider perceptions, community perceptions, and even as far as finding out, like during HIV testing and the bias that presents within the providers of the community, their perception of who is at risk. And that was very interesting. So what we did is we met with HIV testing agencies, we heard from them, we educated them about PrEP and about the resources available, and making sure that, so community, that's where community engagement comes in, and really having a community team that's able to combat a lot of these myths and be consistent and have consistent messaging. So along with doing needs assessments, finding out the perceptions, and putting out we had a lot of HIV education sessions, basic and education around PrEP, and also hearing from the community about what they need. And that's very important. And it also helps communities feel more comfortable to open up about things that they need, that we're willing to listen. And it becomes more difficult, as I said, when social media, really around, particularly around when COVID, because that's all everyone did was social media. You know, a lot of Facebook, a lot of Instagram. So it's really ever more important, we found, to definitely make sure that we have a community engagement team that's able to have a social media presence. And I'm not sure if you're aware of how social media works. You have to have a consistent presence, and a consistent presence with consistent messaging. And sometimes it's not about hard messaging, but about soft messaging. And having that consistent presence, because there's an algorithm on most social media platforms. And, you know, so I can go on today and post on Twitter, but in a matter of minutes, my post is buried. And in Facebook, if you don't post consistently, it doesn't show up on a lot of feeds. So it's ever important to have, if you're going to do social media, because that's where a lot of the information and misinformation and facts exist. You have to have social media engagement, and you have to have to be consistent about it. So what we found is having, we did a lot of webinars, we did a lot of live streams, and Facebook Lives, where we had our providers provide education on PrEP, and we also had question and answer sessions. We had in-person sessions when we were able to, as far as around COVID. And many of them were successful in answering a lot of them. And then you have to have the staff to be able to be on social media, to hear what's going on, to keep your ear to the ground of what's going on in the various communities, and being able to respond. Secondly, one of the biggest things that we find is provider bias. Providers oftentimes do not want to engage in HIV testing and in ordering, even to do an assessment for PrEP. They feel as though, they express feeling that it will increase risky behavior if they order PrEP. Some of the things that we did around that is having PI involvement, which peer-to-peer, having them have individual conversations, offering to come and speak at their physician meetings, their departmental meetings. As I said, it was really important to have the doctors in our site participate in those peer-to-peer activities and have those one-to-one conversations. One of the things we did find to be successful is to find at least one, what we would call a stakeholder, one physician in that department, in the emergency room, in OBGYN, in different pediatrics, and to find a champion to be able to have those conversations and to seek out their interest. Okay. Seek out their interest in providing PrEP. And we have been successful in identifying a few physicians in those different areas. And then lastly, starting educating soon and early with the medical residents and really encouraging them. We have a couple of projects going on, encouraging them to pick up PrEP and educating PrEP early. which has been successful to see the interest involved around that. So in closing, we continually try to address PrEP, try to get the education out there. As I said, it's ever changing. Information is ever changing. Social media is ever changing, and keeping our finger and our ear to the ground to continually be educated. So I think that social media messaging about the facts and having press releases and hard and soft messaging is a solution.
Well, thank you very much. Let's give a round of applause to the panelists, and please come to the microphone if you have any questions. I will start with a question in the chat as you're getting ready to get to the microphone. This is a question for Sisi from Jim Pickett. Can you speak to the lies and misinformation circulating about LGBTQ people in Uganda, which has led to the horrible new bill that has to put so many queer Ugandan in mortal danger? Thank you.
Thank you very much for the comment on the information circulating in Uganda about the bill. The bill was signed by the president. However, it is being contested in courts of law, and at this moment I can't really comment on it since it is in the courts of law, because it is being contested. However, we will be guided, I'm sure, by the government of Uganda as well as the Ministry of Health. Thank you.
Thank you, and we are all, sort of with you for and hoping to support a successful contestation. A question to the right, Melissa.
Yeah, this is a similar follow-up. I'm Melissa Turner, co-chairperson of the Community Working Group for CC, and also Layla as well, I think. Here in the U.S., I think that during the COVID pandemic, the attack on public health experts by our legislative leaders is unprecedented. I can't remember a time where the people that we looked to for factual, scientific expertise, the facts were literally under attack by politicians. And so both of you spoke to the difficulties in trying to deliver facts to your communities when there are larger messages from political leaders that are untrue. And so if you could just unpack a little bit more about how you approach that, how we leverage our relationships with our local community to be able to deliver messaging that is accurate, that is true, and factually based. Thank you.
Thank you, Melissa. I would like to take us back when we had just identified the first COVID case in Uganda. The government of Uganda, in fact, the president himself took part into informing the communities, working with the COVID committee, which was spearheaded by the Ministry of Health. They collected all the facts they could get, and they would relate to the people through different media, as well as educating on the progress of COVID. That helped us as communities to get information to pass on. At the same time, different organizations were working with the support from other NGOs and also international bodies to give us and provide more information. So we had media interventions on different occasions, and also people within the communities. We had health service providers going into the communities, supporting the communities who were in need of that information, and also demystifying the misinformation, the rumors, the myth. Because I told you that people thought if you go into getting vaccinated against COVID, you are bound not to. If you were money, you will lose your manhood, this and that. So those things were being addressed with the Ministry of Health as well as the government of Uganda. There were also some other people who could think no one should really go in for vaccination. But later on, the vaccination literacy from the different health service providers continued, and the people embraced the vaccination program.
Thank you, Leila. You may want to go. I encourage everyone to keep their question brief and their answer brief so we can go through more questions because there's a lot of people waiting on the in the audience. Thank you.
Ok, obrigada. Vou tentar ser breve. No Brasil, infelizmente, nós não tivemos um presidente que atuou diretamente, né, que fez campanha para a vacina e fez campanha para as pesquisas clínicas. Nós tivemos o apoio de algumas grandes emissoras de canais de televisão, que também divulgaram e ficavam em seus plantões 24 horas falando sobre a questão da Covid, da vacina. E também foi principalmente, acredito eu, que o papel da educação comunitária, através dos coletivos criados pela nossa comunidade, difundiu junto com as ONGs e associações de moradores e CAPES essas informações de combate, no caso, à desinformação, porque nós costumamos dizer que no Brasil o que matou foi a ignorância, né? E também um líder que não queria ouvir a ciência. E também nós apropriamos a linguagem, que isso é uma questão muito importante, para que as pessoas que não conseguiram entender o que a ciência estava querendo dizer, nós apropriamos a linguagem para que ela entendesse de acordo com o contexto dela. Em cada local, em cada contexto, tinha uma linguagem apropriada para que aquela pessoa conseguisse adquirir informações claras. E também sempre dando fontes seguras, utilizando fontes como a Fiocruz, que tem o canal Saúde, fontes que de alguma forma, tem muita importância no nosso país. Acredito que foi isso. E também as oficinas online, também nós tivemos isso, feita pelo Transcrições, que nós abordamos vários tipos de tema ligado à questão da vacinação, de Covid, também, e as desinformações. Obrigado.
I'm going to start by reminding you that we had a president then that wasn't very helpful. He was doing nothing regarding campaigns for vaccination and for clinical research, quite the opposite. However, we were able to rely on some TV channels that worked as a source of education for us, that were on 24/7, and they were covering topics like COVID and vaccination. And we had to commit to having education, and we went through different communities to be able to do so. We went through neighborhood associations to psycho and social care centers, and we did that to fight misinformation, because we say that in Brazil what killed the most people was ignorance. And we had to deal with a leader who was not helping us. However, we had to find ways of adapting language to different communities. So we had to take the scientific language and scientific texts and adapt that to different types of context that would be adequate and able to provide clear information. And we went through our association and our research institute, Fiocruz, that has a channel dedicated to healthcare. And we went through other well-respected sources. We carried out online workshop, and we worked also with our collective transcriptions, which is helped trans people to get better information about COVID and fight misinformation.
Thank you very much. So I'm going to go to Betsy to the left. Keep your question brief, please. Thank you.
Okay, I'm Betsy Tolley from FHI 360. I'm struck by the fact that so much of the presentation today is very politicized, and a little bit concerned about that because I do think I started off doing contraceptive-related research, where back in the day everything was about myths and misperceptions, and yet we find that people there's at least a grain of truth, there's a grain of something that's important to them, in trying to just control the narrative and push a message sometimes really backfires. And so I would love to know from any of the panelists, are there ways that we can depoliticize and really have some conversations about whether it's the COVID vaccine or vaccines to come, because I think otherwise we're going to end up in a place where there is just really a lot of mistrust. So I'd love to hear some ideas around that.
So who wants to take that question? Maybe one of you, Emily or Rondalaya, who haven't had a chance to comment yet? Do you have? No.
So I think that's a real problem. In fact, I didn't do as much politics as I could have because a lot of the misinformation is not always equally distributed, and a lot of it comes from the top, and I think we heard that from other speakers. I think one of the things we really want to stress is finding trusted sources, whoever that is for that community, and trying to affirm the places where we can. So affirm the values that we all share, affirm worldviews, even as we try to gently correct misinformation and know that it's not going to be one conversation. It's not going to be like, I tell you you're wrong, and you're like, I admit it. I will fix the past 10 years of decision making. It's a much longer term solution than that. So partners and affirming where we can.
Thank you. In the middle, I'm sorry, I can't recognize you.
Thank you. I'm Laura Barris from Johns Hopkins. Very grateful to all the panelists to the presentations. I think that the medical community is coming to understand that misinformation may be just as detrimental to the health outcomes we're concerned about as the pathogens that we generally concern ourselves with. So I want to ask specifically and try to quickly, what is the state of the evidence around pre-bunking? We heard some strategies from Rondalaya. We like to trial things. We like to gather evidence. Where is the evidence? Where can the medical community be looking within journalism, within other areas to figure out strategies and ways that we can test interventions to improve the situation? Thank you.
So I think pre-bunking is one of the more exciting areas where we are seeing some really good evidence emerging. Now, these are not like huge effects, right? Like we have to think about it again in context that we can make things a little bit better. But there are studies looking at pre-bunking in a lot of different spaces, including medical and politics, and that longer interventions tend to work better, but shorter ones can be effective. And so I think just highlighting that, giving people the necessary knowledge to understand the common misinformation tactics, which we see being used over and over again. You guys are, I'm sure, very familiar with the kinds of the same misleading tactics we see over and over again. Attacks on authority, attacks on facts, false expertise, correlation and causation. Teaching people about those helps them recognize when they're being manipulated, and then giving them a base of knowledge to work from. So I do think pre-bunking is a really important tool in our toolkit, and we need to be doing a lot more on that front.
Thank you. So the last question for today's panel.
Yes, hello everybody. My name is Yves Gephardt. I'm a community representative of Weill Cornell in New York. Allow me to revisit briefly the 80s when HIV was dubbed the great gay-related disease. That was misinformation back then. I can tell you in my neighborhood, I heard young folks saying that if you have sex with a girl standing up, you cannot get her pregnant. That's misinformation, okay? How to combat that? It's very simple. I mean, I'm a Twitter freak. I'm on Twitter 24/7. Some of you know it. The thing is, when I see wrong information, I correct it immediately. I factually, I present evidence if possible, and then I report to the site whatever the tweet. However, the problem is that big tech has decided to roll back information measures. They have decided, for instance, YouTube, this morning on MSNBC it was announced, YouTube will no longer erase messages, wrong messages, or fake messages about the American elections. And that's a problem. So I would like to consider is that a problem with basically the social media giants? They are corporations and they are money-making corporations. Maybe we should start with that aspect.
Thank you for that question. Who wants to take? Emily, you want to try?
Yeah, I'm happy to jump in. I think we need to put pressure on social media companies to do a lot more. The fact that you're out there correcting is fantastic because we know, again, that does work, that people seeing these kinds of corrections are left with more accurate attitudes. One of the big risks right now is that doing so puts you personally at risk of being attacked and doxxed and criticized. And so I think we need to, one, do more to hold social media companies accountable to terms of service against harassment. It's already in there. They just need to enforce that. And two, really put pressure on them to be responding rigorously to misinformation. And I want to stress that it's really bad for English language. It is 1,000,000% worse for non-English language efforts. That misinformation, as much as it's a problem on English-centric platforms, it is even worse in other spaces. And so it is something where we have seen they can do things. Their efforts around COVID suggest there is a lot more they could be doing, but they're not going to do it out of the goodness of their hearts. They're for profit. We need to figure out ways to make sure that it is required of them, or we'll walk, or how can we move policy to make it happen?
I also created the hashtag on Twitter that says, "Let science educate lawmakers." And that's good for Brazil and for Uganda and the United States as well. I created it in 2017.
Just only to add is that I've recently see a lot of community guidelines, particularly on TikTok and Facebook, who have both been to Congress recently, being called to the carpet. So I agree that we have to continually hold them to task about the information that's put out.
Well, thank you very much. Another round of applause for our wonderful panel. The discussion doesn't stop here. I'm sure you may have more questions for them, and I think it's all our responsibility to be ambassador for scientific evidence. So let's do it. Thank you.
We're about to start the very last session of our session, and kudos to all of you who are still in the room. You get the award for stamina and interest in quantitative things. These last talks are meant to be informative and as approachable as they can, but they are naturally somewhat more technical in nature, but I think you'll find them really interesting. I put together this session because of the current wonderful place we are in HIV prevention, where we have developed very effective HIV prevention, and at the Stats Centre in particular, along with our VTN colleagues, we're looking forward and thinking about how we're going to advance new products like monoclonal antibodies or other long-acting modalities, or even topical modalities for HIV prevention when we already have something that works. And one of the strategies we're looking at is what we have labeled counterfactual placebo, looking at ways to estimating what the infection rate would have been if a future trial had actually a placebo. So it's a challenging field. The FDA is interested in it, and I think you'll see in our presentations today, we're utilizing the fact that we actually have two trials, 083 and 084, that were active control trials and did not have a placebo, and using those to help us think through and develop how would we approach a future trial when infection rates we're expecting to be super low, and it's not it's not going to be feasible to do an active control trial. We think that the number of people involved is going to be too high. So 3 completely different sets of ways of going about it. We have about 4 or 5 in the hopper, but I only had the chance to present 3 of them today. So I'm going to start with a model-based approach from Mia on a way at looking at cabotegravir efficacy for long-acting PrEP.
Thanks, Deborah. So this is not a method for estimating counterfactual placebos, but one will be utilized here. And so, yeah, as Deborah said, I'm going to talk about model-based estimates of cabotegravir efficacy for long-acting PrEP by time since injection. So another way to put that is, how does HIV protection wane following cabotegravir injection? This is something that's not that easy to measure with a clinical trial. And so it's a place where modeling can be very helpful because we can make some assumptions with some prior knowledge. And we can here propose a methodology for how we might construct a curve for this relationship of efficacy, and by efficacy I mean reduction in HIV incidence, by time since injection. And here this is going to be in men and transgender women who have sex with men. So I want to emphasize, I've been asked to emphasize, these are preliminary results with data that is incomplete, and they will be updated. However, the preliminary results we have suggest HIV incidence is reduced 97% in this population in weeks 1 through 8. So just as a refresher, which I'm sure none of you need, but I'll say it anyway, in HPTN 083, men and transgender women who have sex with men were randomized into one of 2 arms, receiving either cabotegravir or oral TDF-FTC. And in the cabotegravir arm, the HIV incidence was reduced by 66%. However, this was an active controlled study, and so in order to estimate efficacy versus placebo, we need a counterfactual placebo, and the next 2 talks are going to talk more about that, so I'm not going to step on it. However, this counterfactual placebo will give us a reduction in the intention to treat setting, which means it tells us the efficacy of these products as they were used in the study. And we know that for oral PrEP, efficacy depends strongly on adherence. And even if you look within the HPTN 083 blinded phase, there was a 99% reduction in HIV incidence when you compare individuals who had evidence of at least 2 pills per week versus individuals who had no evidence of efficacy. So, like I said at the beginning, these are hard to study in a controlled study setting, and so modeling is very helpful to construct these curves. So for oral TDF-FTC, the efficacy depends on the number of pills per week. And so this exponential curve was fit to data from the IPREX open label extension, and it's still going to be updated with additional data, such as the data from HPTN 083. For injectable CAB-LA, the efficacy depends upon the time since injection. And this proposed sigmoidal curve, that's a nice math term, is based on non-human primate data and phase 2 studies. However, now that we have HPTN 083, we can update this curve. It will be updated again in the future with data from the open label extension. So just to very quickly go over why we have this sigmoidal curve and the data that we used to support it initially. We first have non-human primate studies. Now, there were many non-human primate studies that supported the efficacy of cabotegravir. I'm just going to talk about one. In this, there was an initial injection of cabotegravir and then weekly rectal challenges of the macaques with simian HIV. And the plasma concentration of cabotegravir was measured at each exposure. So for exposures where the concentration was above a concentration referred to as the PAIC 90, which is 166 nanograms per milliliter, there was a 28-fold reduction in the number of challenges that led to an infection. Whereas when the concentration was below this threshold of the PIAC 90, it was a twofold reduction. Okay. So when human participants receive 600 milligrams every 8 weeks, their concentrations remain on average above 8 times the PIAC 90, and for almost all the participants above 4 times the PIAC 90, even at the trough concentration. And these pharmacokinetic studies from the phase 1 and phase 2 of the cabotegravir trials suggest a half-life of somewhere between 3 and 7 weeks. So if we combine these two lines of evidence, then this suggests the sigmoidal curve that I showed earlier. But it has two parameters that we would actually like to fit to efficacy data. So I will show what happens when we fit this sigmoidal curve to the data from the blinded phase of HPTN 083. So in 083, in the blinded phase, there were 8 infections following about 20,000 injections, and these wonderful visualizations from the primary manuscript, these are not mine, by the way, show the delay between the time of injection and the visit where the HIV infection was first detected. And I'm going to focus in on just one of these individuals, individual D2. They received 4 injections, all on time, and at the safety visit following the 4th infection was when they first had a detectable HIV infection. So we know that it became detectable at some point during this 2-week window. However, the date of exposure to HIV and infection is really unknown. So we can model it. We have some data on how long it takes for the infection to become detectable. And so we don't know if this was indeed since the most recent injection, or perhaps it was during the trough of the injection prior. And so we have to account for this when we're modeling the efficacy over time. Okay, so in order to calibrate the model, we propose parameters, and these parameters describe that sigmoidal curve. And then once we have the sigmoidal curve, we can use it to project dates of infection and detection in the study. And then we can compare those rates and dates to what was actually observed. And we keep these parameter sets if they agree with data. That's a little complicated. So we can visualize the fit by looking at the cumulative incidence of HIV by time since injection. The gray shows what was observed in the blinded phase of 083, and the green here shows our model. But I want to emphasize that there are limitations in this fit. So I mentioned earlier how in the pharmacokinetic studies there was some uncertainty in the half-life of cabotegravir over time, and it may well differ between individuals and populations. And so here I show, what if we fix this half-life at 3, 5, or 7 weeks, and we can see that if you constrain the model in that way, it can still reproduce this data. And so that means that at the moment with the data that we have, we are not able to distinguish between possible different versions of this sigmoidal curve. And I'll show quickly how that might impact our curve. So this is the curve here of efficacy versus time since injection. The bottom panel shows it all the way out to 3 years, but then I've zoomed into the first 8 weeks. So with an unknown half-life, we get, with the full calibrated model, we get a 97% reduction during the first 8 weeks, and then it's still 90%, but please be aware of those wide confidence intervals during weeks 15 and 16. And this 97% during the first 8 weeks is fairly robust to this uncertain half-life, which is good. It means that I can have a little bit more confidence in this number. However, it's still preliminary. Okay, sorry. Yeah. The further along the curve we go, the more uncertain it becomes. And so we can perhaps place a little less stock in this, but as we add more data, we will hopefully become more precise in our estimates. So, just to recap, we created a model-based curve of efficacy versus time since injection. The point here was to discuss the methodology. We will be working with additional data from 083 and the open label extension as it comes in to further refine this curve. Thank you. And wait, I have to acknowledge the OHPT and 083 study team, without which obviously this wouldn't be possible, and then my colleagues at the HPTN SDMC and the HPTN Modeling Center. Okay, now thank you.
Thank you very much, Mia. Our second speaker is Dr. Fei Gao, who works at the Stat Center with me. And she and I have been working on, along with the BTN, on various design options for future phase 3 trials, and she's going to share some of her thoughts here about the idea of utilizing a counterfactual placebo to establish efficacy of novel HIV prevention agents. Thank you, Fei.
All right, thank you all. And today I'm going to present some results on utilizing counterfactual placebo to establish efficacy of novel HIV prevention agents. So for this talk, the main issue we're going to handle is that traditional designs for efficacy trial may not be feasible in evaluating novel HIV prevention agents, given current landscape for HIV prevention. And in this talk, I'm going to introduce this active control trial design augmented by a counterfactual placebo. And we show that it may be conducted to evaluate efficacy of an experimental HIV prevention agent with a reasonable sample size. So based on the results from this study, we show that we may be able to conduct an efficacy trial for evaluating new PrEP agents, such that we may be able to lay the foundation for ultimate literature for future HIV prevention products. So in the past decades, we have seen tremendous progress in the development of biomedical agents that are effective as pro-exposure prophylaxis or PrEP for HIV prevention. So for example, in the realm of oral PrEP, we have TDF-FTC or FTEF, while recently we have developed long-acting injectable PrEP with the CAB-LA. However, even we have so many different types of HIV prevention products, there may still needs to have more diverse new HIV prevention agent to fulfill the need of the diverse population of interest. To evaluate of such new HIV prevention agent, current designs may not be feasible. So this is a graph showing a traditional placebo-controlled trial design, which is regularly used for evaluating efficacy of treatment or prevention products. So basically, in that placebo-controlled trial design, participants will be enrolled and randomized to receive either the new prevention agents or a placebo. And then there'll be follow-up in these two separate groups, and then to see what's the HIV incidence in these two groups of individuals. And here I denote them as lambda E hat and lambda P hat as the estimated HIV incidence for the experimental group versus the placebo group. Then the comparison in the placebo-controlled trial is to directly compare our observed lambda E hat with lambda P hat and see if lambda E is superior to lambda P, such that to demonstrate efficacy of this new PrEP agent. However, given current landscape of multiple efficacious HIV prevention agents, randomizing individuals to placebo arm may not be ethical. In the most recent efficacy trial for CAB-LA, the active control trial design is the one that's employed. So basically, instead of randomizing individuals to the placebo arm, we will randomize them to receive either this novel prevention agent in the context of 083 or 084, it will be CAB-LA arm, or the active control, which is a product that has been demonstrated efficacious in the previous trial. So in 083 or 084, this active control will be TDF-FTC, taken orally. Then in this design, we'll follow both treatment groups to estimate what's the HIV incidence in both groups. and here denoted as lambda E hat and lambda A hat. Then the goal of active control trial is try to compare lambda E and lambda A with a superiority or non-inferiority comparison. Well, the choice of superiority or non-inferiority is basically depending on what is the efficacy of active control product in this trial. So for example, in OA3, we use a non-inferiority comparison, while in OA4, we use a superiority comparison. So in the future, what we're trying to look at to evaluate a new PrEP agent, it's highly likely that we are going to use highly effective active control. For example, we may use the CAB-LA, which has been demonstrated to be very efficacious in OA3 and OA4 as the active control. So when this active control is highly efficacious, and also when this new agent is also expected to be highly efficacious, the sample size are likely to be prohibitively large. So to further demonstrate this idea, I want to show some numbers related to the HPT and OA3, and also relate to a potential future HIV prevention agent efficacy trial. So as many of the audience are very familiar, HPT and OA3 aims at evaluating efficacy of CAB-LA in the MSM transgender population with daily oral TDF-FTC as active control. So this trial employed a non-inferiority design because in the MSM transgender woman population, daily oral TDF-FTC have relatively high level of efficacy. So in the design of non-inferiority trial, the first step is to determine, we call this NI margin, which and is using the notation delta. It kind of quantifies what we meant by non-inferiority to the active control. Because superiority usually we meant that it's just the instance is really higher, but given this setting that daily oral TDF-FTC is relatively efficacious, superiority may not be feasible, and we need to define how much we allow it to be inferior to TDF-FTC. So the DNI margin depends on two parameters. Margin M1, which defines what we expect to be the active control efficacy in this trial, and margin M2 to be the proportion preservation of active control efficacy. So there are a lot of mathematical notation involving here, but one main message I want to deliver here is that by determination of NI margin, we actually also define the acceptable prevention efficacy for the experimental agent. So specifically in the design of OA3, the NI margin is defined as 1.23, where we have margin M1 to be the lower bound of 95% confidence interval of the active control efficacy to be 34.2%. While the margin M2, the proportion preservation is 50%. So those numbers seems a bit abstract, but basically it defines that by non-inferiority, we meant that the prevention efficacy of this new PrEP agent should be greater than 44%. So then, based on the NI margin, we can then employ the study design using the NI margin. So in the design, suppose we are trying to evaluate the experiment agent, which is expected to be 66%. So this is the number used in PT and OA3 design. Then we will need to so this is an event-driven trial. So we need to see around 99 events in the active control arm and 74 events in the experimental arm. So if we're working with a population with 3% baseline background incidence, then we need to recruit and follow up individuals for around 8,700 person years in each arm. So this is the current scale of HPT and OA3 when we design it. So let's move a little bit further. So if we consider a future trial design, when we try to evaluate a novel PrEP agent, where we may use CAB-LA as active control, then definitely the margin will change. And this margin is so much larger than we'd see in the previous slides because we expect to see high efficacy of CAB-LA as active control. So even though we are looking at the same interpretation of non-inferiority, P greater than 44%, but because our active control now is highly efficacious, the NI margin needs to be a little bit larger. And also, we may want to look at a new PrEP agent that is also efficacious. So for example, if we want to have some power to evaluate experimental agent which is 80% efficacious, then basically in a population with 3% background instance, we need to enroll and follow individuals for around 13,000 person years in each arm. So which is like almost a little bit less than double of what we need in HAPT and OA3. And also this number will also change if, for example, this efficacy of experimental agent is expected to be even higher. So for example, if we would like to evaluate an agent that is as efficacious as CABL-A, like 90% efficacious, this number will grow exponentially, because we will need, so the number of events in both arms will decrease because those products are highly efficacious, and definitely will need to use more person years in order to observe such number of events to gain the power. So this leads to our next idea. So how about we can augment the active control design with some other information? So specifically, there's this idea of counterfactual placebo that has been recently discussed in the field. So the counterfactual placebo basically means the HIV incident that would have been observed had the placebo arm been included. So in addition to the active control trial here we plotted, so we also have a counterfactual placebo here. We denoted a lambda p star hat. So we have a star here to denote that it's not this placebo arm that has been randomized, but it is some other information that will be indicative of the placebo instance. So this counterfactual placebo instance has been explored in some recent research. So basically it can come from some different type of information, different type of sources. So one source is to use some historical placebo arm. Specifically, if we have data from placebo arm from some recently completed study, for example, in the same region or even in the same site we're conducting this study, then maybe this placebo arm information can be used as counterfactual placebo. Also, there are proposals of using HIV-RINC data as screening to infer what is the background instance. And this is the idea that has been recently used in the PURPOSE 1 and PURPOSE 2 study from Gilead to evaluate the lenacapavir long-acting product. Finally, there's the idea trying to leverage the instance of other STIs we observed in the trial. So basically, if we have some information of how this instance of other STI correlates with instance of HIV in absence of PrEP, then basically we can try to infer what is the placebo HIV instance using the instance of other STIs in the trial. So today I'm not going into much details of how we come up with this counterfactual placebo. But what I want to show is basically if we have this counterfactual placebo, then how can we integrate this lambda p hat star into our evaluation of active control trial in order to increase the efficacy, our power to determine efficacy of experimental agent. So our idea is motivated by this observation from the non-inferiority trial design. So under a constant assumption for the efficacy of active control, actually the non-inferiority comparison between lambda E hat and lambda A hat can be written as a formula here. So basically, instead of saying that how much inferior this experimental treatment is compared to the active control, actually it's equivalent to what is the comparison of relative efficacy of the experimental agent and active control. And actually it has really neat formulation in the sense that here this gamma is indeed the M2 margin I just introduced, and it indicates what is acceptable relative efficacy of the experimental agent and active control. So naturally, this formulation involves lambda p here. So our natural approach is trying to replace all those lambda p and lambda e, lambda a's by their estimate we have in the trial design, and trying to assess this hypothesis through this test statistics of which basically depends on our observed incidences in the trial and also the counterfactual placebo. So this test hypothesis can be combined with what we usually use in a non-inferiority design, such that it can help strengthen evidence on the efficacy of the experimental agent using this counterfactual placebo. So I will not go into much mathematical details of this, but I want to show you some results of our sample size calculation when we try to employ this additional information. Okay. So suppose we are working with the same setting where we are working with a future trial design using CAP-LA as active control. And suppose that we have some information of counterfactual placebo based on data from external cohort with around 5,500 person years. So here we kind of recognize that this counterfactual placebo is not the true placebo arm. Therefore, we discount their person year by 1.5, trying to offset this greater uncertainty in estimating incidence. So based on this counterfactual placebo, our person year in each arm can then be reduced to around 8,500, so which is comparable to the scale of HPT and OA3. So therefore, by leveraging this counterfactual placebo, we may come up with a trial design that is feasible in terms of our participants' recruitment. To sum up my talk, so I hope I have convinced you that traditional designs for efficacy trial may not be feasible in evaluating novel HIV prevention agents, given current landscape for HIV prevention. And also, by augmenting a counterfactual placebo, the active control trial may be conducted to evaluate the efficacy of an experimental HIV prevention agent with a reasonable sample size. So thank you for your attention. So I would like to acknowledge some of our team members from the Fred Hutchinson Cancer Center and also from University of Washington. And this work is funded by an NIH grant, including the HPT and SDMC and some other R1 grants. Thank you.
So our last speaker is Dr. Shayan Dasgupta, and he is going to continue on this theme, but he is taking a completely different approach, which is using the known adherence efficacy relationship of Truvada to estimate the counterfactual placebo rate, infection incidence rate in HPT and OA3 from which you can derive efficacy. So he will illustrate how this technique would work.
Thank you. So without further ado, I'll just move to my first slide, which is talks about the presentation highlights. So the main issue, the question the presentation addresses is on the same theme. We try to evaluate an approach to estimate the counterfactual placebo incidence in non-placebo controlled trial populations, and HPTN-083 is a very good example of that. And the key finding from this presentation is that we can indeed leverage the adherence efficacy relationship of PrEP agents like TDF-FTC to estimate the counterfactual rate in trials such as 083. And how does the research advance the prevention efforts is that we do know that more flexible designs and just what Faye was talking in the earlier talk are required for demonstrating protective efficacy of newer PrEP agents. So we do think that in that context, this analysis can help inform design of such trials. Again, a very brief summary of HPTN-083. It was a randomized non-inferiority trial to compare long-acting CAP with daily oral TDF-FTC for prevention of HIV infection. Roughly 4,570 participants were enrolled, randomized 1:1, followed for 153 weeks at 43 sites across the world. The primary endpoint was incident HIV infection. The trial ran from December 2016 to May 2020 when it was halted by the DSMB because it met the pre-specified condition for stopping for efficacy. The results were published in the New England Journal of Medicine in 2021. We had 13 infections in the long-acting CAP group with incidence of 0.41, per 100 person years. We had 39 infections in the TDF-FTC group with an incidence of 1.22 with a significant hazard ratio of 0.34. Additionally, in HPTN-083 and more trials that are run currently with active arm being TDF-FTC or FTAF, we had a stage 2 case cohort sampling of drug concentration. And what I mean by stage 2 is that a randomly selected cohort for HPTN-083, there were 390 randomly selected participants from the TDF-FTC arm who were selected, and tenofovir diphosphate concentration were assessed in DBS samples for them. And additionally, we also looked at the concentration of TFBDP in everybody with incident HIV infection, and necessarily at their first positive visit and at selected previous visits. So in all, at least for 083, we had a case cohort sample of 425 participants. Right, so how do we utilize these adherence measurements? And this can be thought of in different ways. In our analysis, what we do is we categorize these adherence measurements into low, medium, and high categories. Then for each participant, you can divide the total follow-up into like contribution to each of these categories. And for cases, the events are assigned to the category that you observe at the first positive visit. And for controls, we only consider follow-up till the last adherence visit before study ends for them. Right, so how to calculate the counterfactual placebo incidence using these adherence measurements. So we pursue this modeling technique under the Bayesian paradigm that was put forward by Dave Clayton and others in 2021, where they looked at similarly the adherence efficacy relationship of TDF-FTC to calculate the counterfactual HIV incidence in the Discover trial. And the salient features of this technique are that it specifies Poisson likelihood for the observed data, adjusted for case cohort sampling. It incorporates drug level data from these case cohort samples and with aggregate data of follow-up and HIV infections by these categories, and also incorporates follow-up data from the non-case cohort samples from the TDF-FTC arm as well as from the CAB-LA arm. A little bit more details about the modeling steps. So we model the counterfactual placebo infections as Poisson with rate lambda naught. So that's the quantity that we are interested in. The infections in the CAB-LA arm are modeled with Poisson with rate lambda 1, and then we write lambda 1 in terms of the counterfactual rate plus the attenuation that CAB-LA has. So alpha here is the efficacy parameter for CAB-LA. So similarly, we can do the same exercise for each of the adherence groups in the case code samples for the TDF-FTC. So in the adherence stratum L, the HIV infections are modeled as Poisson with rate lambda 2L, where lambda 2L is now written as the counterfactual plus beta L, which is the efficacy parameter for the stratum L. And then the follow-up time in each adherence category are modeled as multinomial with parameter rho L, where rho L is defined as a fraction of follow-up time with drug level L. And then finally, those who are not selected for case code sampling, they are modeled as a Poisson mixture with mixing weights, rho L. And for more details, I encourage anybody interested to look at the paper by Dave. Right, one very important piece that we need for this analysis is a quantification of the relationship between seroconversion and these DVS levels. For this analysis, we rely on this modeling exercise that Dave Gladden and their colleagues did, where they developed a two-parameter model for efficacy for TDF-FTC at these three different levels, and it was developed from using IPREX randomized and OLE data. And what it essentially means is that your efficacy, if you belong to the low adherence group, is beta naught, and then when you move to the medium adherence group, it's beta naught plus beta 1, and the high adherence group, it's beta naught plus 2 beta 1. Right, so now we apply these methods. Even before we go to HPTN 083, we try to simulate a hypothetical trial that inspired by what we may expect to find in HPTN 083. And we will apply our methods to those data from those hypothetical trial to show that this can actually be used when we look at the actual trial data. So the hypothetical trial is a two-arm trial of TDF-FTC versus CAB-LA, like 083. We have around 1950 participants in each arm. We have 47 total infections, 36 in the TDF-FTC arm, 11 in the CAB-LA arm, and then we have a further stage 2 case cohort sampling of 291 participants for DBS measurements from the TDF-FTC arm. Right, so when you summarize everything that's accumulated in the trial and summarize by person years and events for the case cohort samples, this is how it looks like. So we have 34 infections in the low adherence group, accumulating about 99 person years, and then 1 infection each in the medium and the high category. However, you have only 11% accumulation in the medium adherence category, but majority was high, which was 64%. And then for non-case code samples as well, we accumulate all the person years that has been collected, was like 2,400. However, no events occurred there because all the cases were in the case cohort samples. And then for the CAB-LA, we don't have any adherence category, so we just summarize everything together. So we have 2,700 person years and 11 events. Right, so one thing I want to pause and mention, the difference between the frequentist paradigm and the Bayesian paradigm. So in the frequentist paradigm, the parameters of probability model are considered non-random or fixed. In the Bayesian paradigm, we often assign or imagine them as random variables with probability distributions. So essentially, in the Bayesian analysis, we have some prior belief about these probability distributions. Then we look at the data, bring in the likelihood, combine them using the Bayes rule, and what we get are posterior distributions of these parameters. And that's what we are interested in. So in Bayesian analysis, first thing we have to do is specify prior distributions for the different model parameters. I would like to consider like how we choose prior for the lambda naught, which is what is the most important salient feature of this model. And we specify 2 different ways. So one is using a flat non-informative prior, which means that we don't have any prior belief what the counterfactual rate may look like, and that's okay. And 2 is informative priors, where you do have some prior salient information that gives you an idea about what the counterfactual rate may look like in the population. And for this modeling exercise, we try 3 different priors, informative priors, one with high incidence with a median event rate of 5 events per 100 person years. The medium incidence has an event rate of 3 median events per 100 person years. And the low incidence prior has a median event of 1.5 events per 100 person years. Right, so so these are the results from this hypothetical trial. And so first I want to point out to the green bars, which are the incidence rate for CAB-LA. And as you can see, across the different analyses using those different priors, the rate is almost constant, which is 0.39. And similarly, when we look at the FTDF incidence rate, which is given by blue, that is also quite constant, but varies a little bit. But when we look at the red bars, which gives you the CHIV rate, that actually varies quite a bit depending on which prior you choose. So if we did choose a flat prior, the estimate is around 5 events per 100 person years, which is close to what we see when we have a high incidence prior, informative prior. But when we have a medium incidence informative prior, the incidence rate goes down to 4.4, while for a low incidence prior, it goes down further to 3.74. Now, since we now have, we can have distribution for incidence rate for all these three, the two PrEP agents plus the counterfactual placebo, then we can also think about how to quantify the efficacy for each of these PrEP agents versus the counterfactual rate. And what we see is that CAB-LA efficacy was projected to be around 90 to 92%. The TDF-FTC efficacy was projected to be about 69 to 75%. Right, so conclusions from this study: some expected variability in the median CHIV incidence based on which prior was used, and that's totally understandable because, in Bayesian, under the Bayesian paradigm, you have your prior beliefs, and then you have your data, and your prior belief might be that the incidence was low, but your data is telling you otherwise. So when you combine the two, you get something that's in between. So that's why you see a lower median counterfactual incidence rate when you have a prior that specifies a low incidence. In the estimated median incidence for TDF-FTC, that varied a little bit across priors, and that's mainly because of interdependence of model parameters. But there was the estimated median incidence for CAB-LA was almost similar across. And the next step will be to apply these methods to adherence and infection data from HPTN-083. And I will, since I have a couple of minutes, I'll talk about some possible extensions. So one possible extension can be if we have placebo data. So if we have follow-up data collected in a non-PrEP period, we can use that to enhance information available to estimate the counterfactual rate. That is, it may be possible to borrow information from other trials that share similar subpopulations, similar geographical locations, similar time frame, etc. We can also allow for modeling the counterfactual incidence rate by adherence category. So introducing heterogeneity and not be same for everybody. And finally, if we can get individual level data and note that HPTN-083 can have individual level data, you can use that to enhance your modeling effort. So you can use that to capture subgroup effect. You can use that to adjust for population differences when borrowing information from other studies. And very vitally, we can perhaps use the participant characteristics to build a predictive model for adherence and impute the adherence profiles for people who were in the non-case cohort samples from the TDF-FTC arm. And that way, it's probably, you can do a better job of modeling this for the non-case cohort groups. And that's it. Thank you. This is one of the resources.
So we now have some opportunity for commentary or questions to the speakers. This is an area of active research, as many of you know. Rafi.
Thanks, and thank you to all three of you for really great presentations. I can't say how critical these various modeling techniques are for understanding really what the future of this kind of work is likely to be as these more classically comparative trials become infeasible from both operational and financial perspectives. So congratulations to all three of you. I think this is really exciting work. I think we all worry that models are so governed by their inputs and the nuances of the model itself as to how to interpret these things clinically. And I'd love each of your thoughts on what the potential limitations of the model outputs that you're creating are for what's largely a clinical audience here. And Cheyenne, I wanted you to, if you could, wax poetic a little bit. Deborah and I have been machinating about this notion of using a TDF-FTC or tenofovir-based control arm and back calculating from known correlations, efficacy reduction. And these Bayesian techniques, I think, address a lot of the potential biases associated with that mechanism, but what biases are we not able to remove using statistical methods that still could plague the use of that that construct or that model as we look forward to other potential tenofovir controlled arms. So thank you.
Cheyenne, go ahead.
Hello.
Yeah, I think you're on. I think it's on.
Yeah, so yes. Yeah, about the potential biases. Yeah, so in every modeling exercise, one thing that we always worry about is confounders. So we can always miss confounders, and that's why this exercise that I talked about is mainly based on summarized data, so it doesn't involve individual level characteristics. And that's where I think the future extension, at least for this method, lies. And I feel that if we get good quality data, we can do these modeling exercises with a lot more confidence. And that's why in trial settings, it's important that we spend a lot more time in doing modeling across different trials to see what kind of estimates we see in different under different paradigm, under different subpopulations in different geographical locations. And the other thing, because these are model-based inferences, and as you said, there are a lot of sensitivity to model assumptions, I feel like no one way of estimating the counterfactual is going to be probably enough. Probably we need multiple ways of estimating the counterfactual in the same population and try to see whether what answers we get and sort of integrate them in coming up with an answer.
Mia, did you want to comment at all?
Yeah, is this okay? So I think, it's very important to look at multiple different approaches. So, I mean, I've used here this sigmoidal curve, but there are other ways to kind of construct this. And so, we need to look at the sensitivity to these assumptions and see which of the results are robust to differences and which of them aren't. And I tried to emphasize that some of these results were robust and some of them were not.
Sten, would you go next?
Sten Vermund, Yale. As we think of carrying innovation to the FDA, are counterfactual placebos being used in any other fields, such as cancer? Because we have analogous challenges in those fields. And I guess Wafa had exactly the same question.
I mean, I would comment that the FDA has put out guidance about this, so it's certainly something they're conscious of, aware of, thinking about, and open to. We also, in a way, and we also know that is the way Gilead is proceeding with their lenacapavir efficacy study with you never get the blessing of the FDA, but without a strong objection from the FDA. It's a very good question, and I think I can't explicitly answer your question. Veronica can. Excellent, Veronica.
Hi, thank you. And thank you for these great presentations. Faye, it's really nice to see the continuation of this work on the counterfactual that we had started discussing in our working groups. So that's really, really great. So the FDA, basically, the Division of Antivirals, has said, I mean, they haven't published the guidance on this yet, but they've basically said, yes, let's proceed with the counterfactual approach. We'll monitor it closely, and the forum's PrEP working group will continue working on that as well, together with the FDA and the European Medicines Agency as well. We also work with some of the African agencies so that everybody is sort of following this together to see how well does it actually perform. So all of this kind of work is very informative for that. And in the cancer field, what's done a lot is also external controls, sort of the natural history of what would happen without the treatment. So the counterfactual is sort of an external control, and there definitely are a lot of guidances about how to use external controls in different scenarios.
Yeah. I mean, it's interesting, this language thing. I mean, I've chosen to proceed with the counterfactual placebo, not because there's any placebo, obviously. It's more that conceptually, to try and keep the idea that we are trying to estimate the placebo that would have occurred in the trial, which kind of brings along with it the similarity of characteristics, balance in characteristics, really trying to, as far as possible, do as much as we can to replicate what we really believe would have happened in this particular population. So that's
right.
Part of that. The language is really part of trying to capture that concept.
Right, because a randomized placebo is really the best counterfactual. And often when we start talking about the counterfactual, it was sort of a novelty to people to say, oh, a placebo actually is the counterfactual.
Right.
So we're just constructing it without randomization.
Without actually using it. You've been very patient, and we're not going to keep you very much longer. Thank you. Thank you all.
Good morning, everyone. And we are almost at the very end of our agenda, but the most exciting part of the agenda. First, I'm not Qureisha Abdul Karim. She could not be here for her own personal reasons, so I'm filling in. So we are now at the Network Award part of the agenda that is always very popular with all of us. And this year, the network is presenting awards to the teams of 2 studies. The COVID years, as we all know, has been particularly hard for all of us, but especially for those of us who are conducting research studies, who are participating in research studies, and for engaging, recruiting, and retaining participants. And the HPTN studies that have overcome all these challenges despite COVID. The first one that we would like to acknowledge is a study that is evaluating interventions in transgender people. This is our first fully focused on transgender people study, and we are very, very happy to acknowledge all the efforts of the HPTN 091 study teams to meet its enrollment. So, the 2023 HPTN Accrual and Retention Award goes to the Bridge HIV CRS, San Francisco. If you are in the room, please come up here. Susan Bunkbinder, the fearless leader of that clinical research site, is coming up. Do we have the awards, Cameron? Okay. The next site that be ready to come up here is Harlem Prevention Center, New York City. Wafa, Mike, can you come up here? Susan. Oh yeah, I think he wants, Mike and Wafa, they want it in front of this. In front of this? Yes. Once again, a round of applause. And now I'd like to invite the Harlem Prevention Center. And the next site is the Penn Prevention Center from Philadelphia. So please get ready to come up here as well. Anyone left from the Penn Prevention Center? Oh, there's David Metzger. Great. And the Houston AIDS research team and the Evander Chagas team be ready as well. The Houston AIDS Research Center, anybody from that site? Okay, but I do know that, oh, there's someone. Good. And last, the Evander Chagas IPEC site. Oh, Valjalia, come on up. All right. And the second study that also had a very challenging job and actually used mobile vans to recruit, engage, and retain participants is HPTN 094 that enrolled people who inject drugs. So again, the 2023 Accrual and Retention Award goes to UCLA Vine Street and Clinical Research Center, and I see the fearless leader of that site sitting there. Others can join as well if you're in the room. Okay. As we all know, Steve Shoptaw is also one of the protocol co-chairs of that study. George Washington University Clinical Research Center. Anybody from George Washington? Okay, Melissa. All right. And the next site is the Bronx Prevention Center, so please be ready. So Melissa Turner is going to get the award for the George Washington University Clinical Research Center. Okay, Bronx Prevention Center, CRS? Okay. David Metzger will have to come up again for the Penn Prevention Center, or somebody else at the site. Okay, great. A round of applause for this site. Two difficult populations, and they've done a marvelous job of engaging them. And last but not the least, again, Houston AIDS Research Center. Another site that had to recruit two studies concurrently in a very difficult time period. Right. Okay, that concludes our network awards. Thank you very much, and I'm going to ask Mike Cohen to give the closing remarks.
Well, I will be very brief. Number one, there are lunch bags outside, and I will describe that there are vegetarian, oregano chicken, and roast beef. That's probably my most important announcement. And there's a lot of them, so please take them. Second, I really want to thank everyone who is here today and all who came and all who were online. I think it was a particularly good meeting, actually. This is hard coming out of COVID. I've talked a lot about the COVID opportunity cost. We did not have meetings for, 2 or 3 years. Last year, I think, was really quite difficult and maybe not as inspiring because we were wearing masks and, everybody was taking tests every day and so on and so forth. This year was more relaxed and more convivial in every possible way, and I think really laid out where we've come from and where we're trying to go, which is probably the most important. Where are we going? And I think that's been conveyed very, very clearly. We especially thank everyone in this room for all their contributions and for dealing so well with the community and participants and studies, which is what this is all about. We especially welcome ideas, like new ideas. At any time, anybody can have an idea. We have consider us a giant idea box, because that's what we need. So safe travels to everyone wherever you're going, and we'll see you in Africa, those who live in Africa, September 27th, 8th, around then. And we'll look forward to that. So thank you and have a great trip. Bye.